we are waiting. Prof. Salman Rawaf is our chairperson of the whole society, the Arab Public Health Society. Meanwhile, maybe I can proceed, but I would like his presence because he has a musical voice and he has his own art of presentation. Prof. Salman, where are you, Prof? Okay. Musical voice and he has his own art of. So this is, with all respect, this is the fourth webinar we are doing at the Arab Public Health Association. And my respected colleagues, audience and participants, good evening everyone, and I wish you a pleasant life and time with us. Today, under the under the leadership of Professor Senna, and she is a professor of public health, King Mohammed University, Morocco, and with the distinguished speaker, Dr. Edward Kelly, is the director of the Integrated Health Services and lead WHO COVID response on health services and system, WHO Geneva, and my brother, Dr. Awad Mataria, is director of health system and universal health coverage, WHO EMRO Cairo. So the panelist is leading by His Excellency Professor Salman Rawaf, is the president, as I said, of the Arab Public Association, and myself. I will give the lead and chairmanship for my sister Professora Senna. So please, the floor for you. Thank you so much.
Thank you, Professor Khoja. Hello, everyone. So on behalf of the Arab Public Health Association and on behalf of all my colleagues, I want to thank you for joining us today in the fourth COVID-19 webinar that will be focusing on health systems today and post-COVID-19. So before introducing the first speaker, please allow me to highlight briefly the context of health systems in all around the world that was confronted to an unprecedented situation. There was an emergency of ensuring surveillance, response, and prevention, ensuring communication, control, managing risks, preparing hospitals, intensive care beds, supporting and protecting human resources, and working with other sectors. In our region, in the Arab world also, human systems have reacted to this situation, both with some successes, but also with some constraints, among which I can cite the financial and human resources that were insufficient, the critical equipment, the governance, specifically the partnership between private and public sectors, the partnership also with the health insurance agencies, and also with academia, so that there were a lack of scientific production for decision makers. There was also a lack, and it was noticed during the last webinar, a lack of integrating primary healthcare services. More than that, health systems, faced to all these challenges and difficulties, have directed all the resources to COVID-19, which will certainly have serious consequences in terms of mortality and morbidity. So let's say that in few words, the pandemic has shown that it's not only about budgets, but it's also about human resources planning, about governance, about management, and about widespread health coverage. So to go in deep and discuss all these topics, please allow me to introduce, and I'm honored to introduce Dr. Edward Kelly, the Director of Integrated Health Services and lead at the WHO. Dr. Kelly, the floor is yours.
Great. Thank you so much for that kind introduction. And also, just personally, it's a great honor to be here with the association and also with Dr. Salman and Dr. Khoja, we have long history, Tawfik and myself, of many patient safety discussions back in the early days of patient safety, back before actually it was an accepted idea that maybe infections happened in healthcare settings, maybe surgery mishaps happen and these types of things. And now we are in the midst, and this is part of the point of my talk, of perhaps, I suppose, the biggest patient safety incident globally that has ever happened. And so I think it's this idea of addressing the challenges of COVID, just as our chair was saying, and also simultaneously addressing all of the essential services that our populations need is a big challenge. So I will, and it's also obviously a great honor to be here with my colleague Awad Mataria, who's doing just an amazing job within the Eastern Mediterranean office, and by far with a wonderful regional director, has really energized the region and has really come up to the challenge. So I will perhaps talk of some of the broad strokes, and then the really interesting part Awad will talk about, I'm sure. So if I can just, I'll share my slides and make sure then to go through as quickly as I can. So the maintaining of essential health services is something that our own Director General has highlighted is a major issue in terms of both this particular outbreak, and we say often that the outbreak has done nothing if it doesn't expose the issues that we have and challenges we have in our world and cracks that are there, that there's no health security without resilient health systems. And that really also the best defense against any outbreak is a strong health system. And COVID is revealing some of the cracks that we have in those systems. And the challenges we have are the immediate rise in the large number of patients needing to be cared for by COVID. And this is a new virus. Many things we didn't understand about it clinically, but that's demanded, put big pressures in terms of supplies and equipment. I mean, this is personal protective equipment, but other products as well. Big burden on healthcare workers and all around a disruption of health services. So how do we balance the demands of responding to this outbreak with coordinated action that allows us to maintain quality essential health services? And these are issues actually that we talked about as part of the Lancet Global Commission on Quality that highlighted that there are 8.6, we estimated 8.6 million deaths per year in low and middle income countries due to inadequate access to quality healthcare. And really, there's only about 3.6 million people who were not able to access care, and 5 million who access care but received poor quality. So the burden is both an issue of access and quality at the same time. And these are questions we need to address now. This is a sort of conceptual graph of what has happened and what we're seeing in many countries in the region and globally. That you have a rise in terms of the COVID, the response on COVID in the purple line, and a dip in demand for essential health services. But then as things start to come under control, many countries have figured out ways of public health measures and also social measures to try and address this. You are able to manage this, but there's a pent-up demand for essential services as that comes along, and a need for your primary care, your hospital care, and other community care to be involved in test and tracing and isolation. And that's something we're working on now. But there are also demand for new services around mental health, rehabilitation. We don't understand what the rehab needs will be, and social services. So this gives you a picture of the health impact over time. We have direct morbidity and mortality. You have the interruption of other health conditions that then surges. You have bumpy sort of tails for the COVID morbidity and mortality. And the UN has talked a lot about the overall impact, economic, social, and other service-related impact over time that will be some of the health impacts we need to be tracking. So WHO is involved on research and development on preparation and preparedness rather and response, but then also coordinating the global response in terms of our partner platform and the work on essential medical products and how people can protect themselves in terms of communicating to the public. So all the different core functions of WHO. And I won't go through all of them, obviously, because there's not time, but really to talk about some of the key areas we've tackled has been around essential health services. And we've had 3 main documents that I would, the web address is there, but I would really encourage people to look at. The March guidance came out quickly, and for the first time since I've been at WHO, and I already talked about, Professor Tawfik is a very young man, but I'm much older and was involved at WHO for a long time. And the first time ever since my time at WHO, we have essential health service as part of the response on an emergency. So that was due to that first March guidance that came out, giving programmatic priorities for ensuring essential health services during the outbreak. People then said, well, but health workers need to leave the facility. They have to go out into the community, and we shouldn't on Monday tell them one thing because they're doing immunization activities, and then on Tuesday, because they're handing out malaria bed nets, tell them something different. So we need to come with a joined up approach. So that's the second guidance, talks about when you're working on outreach and community-based care, how do you do it safely? And then our regional directors told us, well, that first guidance, very useful, but it's not detailed enough around specific populations and around specific diseases. So that's what we tackled and updated in the third guidance. I'll mention quickly what it did. It superseded that first guidance. It focused on country implementation. It outlined adaptation. So it's not everything you need to do for taking care of elderly people or everything to address different neglected tropical diseases, but it's the adaptations needed during the COVID pandemic. And then it's really intended for decision making and managers. And it covers these 2 key areas of strategies and then going through the details, and has an annex with indicators. And this is the outline of the first section. So it talks about setting up governance and coordination mechanisms, come up with a list of priority services, and then look at how they should be adjusted and set up across your different service delivery platforms, and examine patient flow and your workforce capacity. But then look at the other issues of medications, looking at financial barriers and reducing them at the point of care. What are the communication strategies and monitoring you need? And we've also added work on the digital strategies. Many countries experimenting, and in the region particularly looking at digital ways of delivering and care. So this is I won't go through each of them because there's it's really quite detailed, but this is the kind of content that's in each of these areas. So on prioritizing essential services and adapting to changing context needs, looking at coming up with that context and country specific list, but look also at marginalized populations, what you need to suspend, what's the roadmap for progressively reinstituting services and anticipate that, and then look at some of the associated systems that are associated with it. This is what some of the guidance we had on the service delivery settings and platforms, including a functional mapping, ensuring 24-hour acute services are available, and really looking at the referral pathways for how patients can move or be transferred and move between different parts of the system. Often infections and adverse events happen in those. And a number of other key pieces, particularly around redesigning how you handle chronic disease management, so it doesn't fall through the cracks, and it's not only at distance services. The safe and effective patient flow also goes through a special examination of the minimum requirements for IPC, the supplies you might need, and how you really handle these very distinct concepts of screening, which is not the same as triage, and then isolation, and these different pieces that are there. The second part of the guidance goes through the different life course and disease considerations. So what for different populations are the specific adjustments you need to make? And then a section on nutrition, non-communicable diseases and mental health, and then on communicable diseases. And again, these are the types of issues that are there. For instance, looking at life course for children and adolescents, what are the program activities? You can see the table there. What are the modifications for the safe delivery of those services? And then how do you start thinking about coming back to normal? What are the activities that you should start planning for? These are some of the indicators, and I won't obviously go through them. We have 3 key indicators that are part of the monitoring of our activities in terms of essential services. We have this longer list that countries are asked to look at as potential ways of monitoring the impact on essential services. And this relates back to WHO's 100 core indicators, back to our primary healthcare operational framework monitoring that we just presented to the World Health Assembly this year. So it's linked back to existing consensus indicators. And all of these are framed within sort of 3 key roadmaps that the world has. Maybe this is news to some of you. It often is when the UN does something, sometimes it doesn't tell people enough. But WHO has its strategic preparedness and response plan with a number of pillars for the response on COVID. And the last pillar, the final pillar rather, is on essential health services and systems. For humanitarian settings, the Global Humanitarian Response Plan takes those same pillars and applies them in fragile, conflict affected and vulnerable settings. And also essential services is a key piece there. And the bridge to the UN's socioeconomic response plan, so to the longer term socioeconomic work, is again this health first approach. So essential health services as the first thing that needs to be placed in terms of the longer term of the social services and protecting people and economic recovery, including jobs, and working back towards the recovery work. So I'll just finish with a few slides on what we've learned about essential health services and systems and the interruptions. We presented this just this week. Awad has been on some of the calls with us to our regional colleagues, and I think there's a lot of richness to the data that I won't be able to go through. But again, I mentioned we're really, initially we looked at several key indicators on immunization rates and facility institutional births, and as well as broader services disruption. And these are part of a broader monitoring and evaluation framework that WHO has for the SPRP, our COVID plan, working with all countries globally through our regional offices. We did a rapid assessment of the continuity of essential health services, looking at policies and plans, looking at the maintenance of essential services, and then on the priorities and the technical assistance needs. And the first thing we saw is that it is true that most countries have set out a defined essential health services package. So what are the essential services that they need to keep running during COVID? But much fewer countries, only about 50% of countries, have provided additional government funding for the maintenance of essential health services. And there's a lot of reasons for this, partially probably because typically this is seen as kind of something that's outside the response. But given the framework of COVID and the fact that we will be working in this mode for quite an extended period until not just we find a vaccine, but we get it to everybody out there, and I'll close with that in a minute, that we will need to be upping this number from 50%. But the early results, over half of countries have suspended or limited at least one service delivery platform during COVID. And this gives you a picture from outpatient services and community-based care, which have been the most impacted, all the way down to pre-hospital and emergency unit services, which is good that those are less impacted, but even 5% of emergency units across the globe being shut down is very worrying itself. And many countries depend on these outpatient and community services on the other end to get essential services running. The countries reporting disruptions across 25 essential services. And we can see that some of the ones that are most disrupted have to do with rehab, routine immunization, also dental services, but non-communicable diseases, diagnosis and treatment, family planning and contraception, and the implementation of planned insecticide-treated bed nets, all in that top area, as well as mental health disorders. These were some of the top ones across all the countries in terms of the
Excuse me, Dr. Kelly, I may interrupt you, just have 3 minutes left.
Yes, thank you so much. These were some of the services most interrupted across the different pieces. And I think it gives us something to focus on, but it's not just a sort of supply picture. 78% of countries noted decreased outpatient volumes as the main cause for the disruption. So that means that it's not just that the workers and the services are not there, but people are not coming. And that's part of the reason. It's this mix of supply and demand factors that our colleague from India highlighted. 2/3 of countries have identified triage.
How are you doing, sir? What about, are you talking?
Yeah, shall I keep going here then? The 2/3 of countries have identified triaging in terms of identifying priorities as a primary way of overcoming some of the disruptions. And also people have identified other factors here. For instance, down at the bottom, government removal of user fees. That's something we said that at the point of care needs to happen across countries, and very few countries are actually doing it. But they have identified—
Why you are ignoring me? You are racist. Why you are ignoring me? Please answer me.
The top priority and technical assistance needs for maintaining services have been highlighted here in terms of PPE, capacity building, guidelines and tools, sharing experience and best practices, and also telemedicine, all key elements. We are gathering more information. We'll be working with the regional offices on this in terms of a harmonized health service capacity assessment. These are some of the areas covered, and I would really encourage to get feedback. But with my last slide, these will be some of the issues we'll be measuring. And I think it's quite clear that we have a good picture, at least as countries report, of the disruption areas. We have some tools, but how do we get that really moving in countries, I think is a question that really our regional offices and country offices will have to work across 3 levels of the organization on, and with civil society and with associations like the ones we're talking to today. So maybe with that, I'll finish, hand back to our chair, and I'm sure we will hear more about the action areas that need to be considered with my colleague Awad. Thank you very much, Chair.
Thank you very much, Dr. Kelly. Thank you for this enriching and inspiring presentation. So let me introduce Dr. Awad Mataria, the Director of Health Systems and Universal Health Coverage from WHO EMRO in Cairo, and who will talk about how COVID-19 has affected many things as UHC goals and the resilience in health systems. Dr. Mataria, the floor is yours. Sorry, but we cannot hear you. Can you unmute your microphone, please? Dr. Awad? Can you unmute your microphone? We cannot hear you. Yeah. I think it might work now.
Can you hear me now?
Yeah, sure. Thank you.
It seems that I've been muted by the host, but sorry for this. And again, thank you very much for the opportunity. It's a great pleasure to be connected with all of you. I participated at the previous webinars, and I have been really fascinated by the level of discussion that we were having from all colleagues from the Arab Public Health Association. And it is really an honor to be speaking after Dr. Ed Kelly, and especially with all the great work that he's doing in the area of looking at how to sustain health services in the context of COVID. So if what Ed has taken us through was really a journey in what I would qualify as the ultimate aim of the health system, or even the, if I may use this term, la raison d'être of the health system, which is the service delivery, how to make sure that services are there and they are reaching to the people who are in need for those services. What I would like to do is to take a step back and to look at the overall health system and how the health system does make sure that these services are being provided. And I'll share some reflections about where we are coming from and where we are going for with regard to our thinking around health systems. I thought that it will be useful to start the discussion by taking us to one of the definitions of what we mean by health systems. And one of those definitions indeed is going back to the year 1981 to Professor Romer, who was one of the first people who thought and who wrote about health systems. And Professor Romer, when he was trying to define health systems, he used an organizational management approach where he looked at the different inputs and different outputs into the health system. And he was saying that this is the mechanism through which a health system is able to contribute to the improvement of the health of the population by taking into consideration different inputs into a sort of a production process that would contribute to improving the health of the population. But then that has evolved over time, and we all know, I mean, in the year 2000, the World Health Organization published the World Health Report 2000, which was the first report that tried to provide an overall definition of what we mean by health system. And that report defined health system as all institutions and activities whose primary purpose is to promote, maintain, and restore health. And I highlighted a few words in this definition in order to emphasize the importance of all institutions that are involved in the production of health or in the improvement of health of the population, but also to look at the different activities and that are involved in that regard. But a key word in the definition is the word primary, meaning that there are different systems that would contribute to the improvement of health, but the health system is the only one where the primary intent is to improve or to maintain or to restore the health of the population. A few years later, in 2007, WHO published another report that tried to dissect the concept of a health system into what became to be known as the building blocks of the health system or the components of the health system. And there are six components, 6 building blocks. We are all aware of them. I will not dwell much on those, but these are the different functions of a health system that have to work together in order to fulfill different goals that have been identified then for any health system. And the goals that we were looking at the time were to improve health, to respond to the non-medical need, to ensure financial protection and social protection, but also to guarantee efficiency in the use of the resources in the health sector. Now, if we come to the current pandemic and to the current crisis that the world is faced with, what we notice is that COVID has really affected all the components, all the functions, all the building blocks of the health system. I would just like to highlight a few of those challenges that we have observed in this global crisis that we are still living. What we are noticing is that COVID has really demonstrated the importance of good governance, the importance of coordination, the importance of leadership in the health system, within the health system, or even across different sectors that contribute to the health of the population. COVID has also highlighted the weakness of the health financing systems and the rigidity of the public financial management systems in countries, where we are noticing that in countries which are trying to mobilize more resources for health from public sources, they are faced with challenges in order to allocate the funds from one place to the other because of the rigidity of the public financial management systems in the countries. It also highlighted the challenges related to the current models of service delivery. We have noted that the primary healthcare is not prepared in most of the countries, mainly in all countries in our region, in order to do functions like triage, like contact tracing. But also we are noticing that the hospital sector became quickly overcrowded and became challenged to guarantee the provision of the needed health services. And also with regard to the medicines and technologies, what we noticed with COVID is that with some of the responses that are happening, they have been associated with irrational selection, irrational distribution and use of medicines and medical products. And last but not least, we noted how hard the health workforce has been hit by this pandemic. And we noted that how the health systems in most of the countries of the region have been suffering from shortage of health workforce in many specialized areas, like in ICU or infection disease, in the area of infection diseases, or in areas of specialized services, like for the question of pulmonologists. So what we have tried to look at as a bigger picture is that through this impact on the different components of the health system, we note that the COVID has impacted indeed on all the dimensions and all the goals of what we call universal health coverage. We know universal health coverage means that everyone should have access to her or his needed health services in good quality and with financial protection. And what we notice is that COVID has affected all these goals of universal health coverage. With regard to access to services, Ed has already referred to the interruption of certain services, especially with regard to non-communicable diseases. We see that in many countries there is a delay in some non-urgent services. We see that there is an increase in the flow of patients to primary health care because of the fear of patients to go to hospitals or to specialized centers. But we also notice that there's a shortage in medicines and medical products, including blood and blood products. And we were highlighting this indeed 2 days back because it was the World Blood Donors Day, and we have been noticing the importance of blood and blood products in that regard. On the other goal of universal health coverage, which is financial protection, we noticed that COVID has really impacted the capacity of people to be able to pay for and to remain financially protected when they are using their needed health services. First of all, COVID has been associated with a negative economic impact at the national level and at the individual level, which has increased the risk of financial hardship and impoverishment. We have some numbers from some countries in the region. I'm highlighting some of those, but I'm sure that in other countries also, there are an increasing number of people who are faced with financial hardship because of the current pandemic. And the last goal of universal health coverage, which is equality, we notice that there is an impact on the health workers, but also the patients who are using care with regard to getting infections while receiving their care, what we call nosocomial infection or healthcare acquired infections. We notice that there's an increase in the off-label use of medicines on which there isn't enough evidence or on their efficacy or on their safety. But also we notice in some countries there has been an increased number of falsified medical products and falsified medicines that are still under experimentation, but people are trying to use them in order to get cured from the current pandemic. While health system has been hit by COVID, we also see that health system can play a major role in addressing and responding to the pandemic. Health system indeed can play a central role in preventing the cases of COVID and in managing those cases. But also health system is very important in order to ensure the continuity of care, and this is the talk that my colleague Dr. Kelly has referred to, and to prevent any future outbreak or any future pandemic. But what we have also noticed is that even the most advanced health systems in the world have been hit hard by this pandemic. And this, for us, made us think about how we should reconceptualize what we mean by health system, how we should restructure health systems in the future, in the possibility of a post-COVID era to come. When we looked at how health systems have been conceptualized, have been structured in the pre-COVID era, we can see even from the frameworks that I shared with you that there was a very big focus on the efficiency goal of the health system. There was a look at the health system from its nationalistic definition. So this is the health system of country A or this health system of country B. And there wasn't really a look at the global public health in its totality. There was main focus in the health system about the care component, about the curative and rehabilitative part, and maybe less to the promotive and preventive side of the health system. And there was a big emphasis on the role of the health system in economic development and economic growth. What we are proposing is to have this shift in our thinking about health systems in what could be qualified as a post-COVID or an extended COVID era, whereby we would like to see more thinking about access to needed care, more focus on the equity in accessing the needed health services. There should be a more focus on the global solidarity, so looking at all health systems together globally. There should be more focus on intersectoral collaboration, but also on the importance of comprehensive emergency management as part of the health system. And finally, there should be special attention given to public health and to the social determinants of health as part and parcel of the overall health system. So our proposal, and this is the thinking where we are heading for, and this is what I would like to qualify as health systems post-COVID in a way, is to look at health systems with a main feature for those health systems that is a resilient health system. So the question is how to establish a resilient health system that would help us to move towards two goals, which are universal health coverage and health security. So in the past, universal health coverage and health security were seen as two different goals of the health system, and you would design the health system towards one of these two goals. But what we are trying to think about is how to marry these two goals together: universal health coverage and health system, and health security through a resilient health system. And we believe that this could happen by integrating what we call essential public health functions, or the common goods for health, along with the components of the health system. So what you see here are the components, the ones that I went through, the building blocks, and the essential public health functions. There was an exchange today on the WhatsApp group of the Arab Public Health Association on what we mean by public health and the essential public health function. And Professor Rawaf was referring to the work that we did a few years back. And this is what you see in the middle of the screen are these 8 essential public health functions that we have identified. 4 of them, we qualify them as core functions and 4 as enabling functions. So those really need to be integrated and to become part and parcel of our all thinking about health system. But also there is a piece of work that was published last summer on what we call common goods for health, which are similar to the essential public health functions. So these are goods or commodities or functions that cannot be financed except from public sources, and that should be made available to everyone without excluding any individual in the society. So just to briefly, if we want to say that we want to have a resilient health system, so it's very important to define what we mean by resilience. And I'm very pleased to report that a group of researchers from the Arab Public Health Association has taken that question forward. And now we are trying to rethink the question of resilience, given the learning that we are getting from COVID. But in a nutshell, what resilience means in the context of health system is to have a health system that is able to resist any crisis, to be able to absorb that crisis or that shock, and to accommodate itself to that shock, but also to emerge from it, to recover from it, and to emerge stronger than before. And to do that in a timely and efficient manner. Of course, there should be more adaptation to this definition, and this is what we are trying to do given the COVID lessons and the learning that we are gaining. So now, if we want to have a resilient health system, and I explained to you what we mean by resilient is where we want to merge the essential public health functions with the health system components, then what we are proposing is a sort of step-by-step approach in rethinking the rebuilding of the health system. And what we find is that all systems in the world, and in particular in our region, should really invest in what we would qualify as step 0. So even before thinking about institution, things that are really of essential public nature, things that are of common goods nature, like surveillance, like regulation, public health, health information systems, IPC, infection prevention and control. And this is where a real focus should be given in rebuilding the health systems post-COVID. Once this is done, then we can go to step 1, which is about the foundation of the health system. And these are known. I mean, we have been working on those for a long time. It is about building infrastructure, facilities, primary healthcare facilities, hospitals. It's about producing health workforce to deliver the needed services. It's about establishing supply chain or emergency management capacities in countries. Once this is done, then we can talk about institutions. And institution is a huge agenda. It's very important for the countries of our region. It is where we would like to have institutions that allow us to move towards universal health coverage and to guarantee health security while ensuring intersectoral collaboration, bringing in the different stakeholders. And the last step is where we can think about transforming the health system in order to become the health systems of the 21st century. This is where we can talk about people-centeredness, the question of public financing, equality, the question of decentralization in some countries, especially in large countries where we would like to go at the subnational level in a way. So this is a sort of a step-by-step approach in
Excuse me, Dr. Mataria, just 2 minutes, please.
Sure. In rebuilding the health, I'm almost done. And this is where we can see the investment that is needed to rebuild the health system. Just to conclude, the way that we are taking this work forward at the regional level is to divide the work into 3 pieces. So we are working on assessing the current response on health systems to the pandemic. We are working on the question of rebuilding the health systems from a resilience point of view. And we are looking at how to invest in essential public health functions in order to build back better health systems. And these are 3 different streams of work that we are having to move forward. I think I have this slide, which is my very last slide. If I want to conclude, then it is the message that I would like to share with you is that universal health coverage and health security are noble goals, and these are what we want from the health system. However, what we do in the health system is what we call health system strengthening, is all the different measures, all the different approaches that we try to implement in countries to move towards that goal. So to try to distinguish between what we do and what we want from a health system is something that is very important in order to inform the agenda forward in rebuilding the health systems. And I thank you very much for your attention.
Thank you, Dr. Mataria, for your very interesting presentation. I think we can start the discussion now, and I'm honored to invite our experts in public health, and especially in the Arab world. We have with us Dr. Dina Al-Usfour, who is from the Ministry of Health of Sultanate Oman, Professor Salman Rawaf, the President of Arab Public Health Association, and Professor Tawfik Khoja, the Vice President of the Arab Public Health Association. We have also with us, maybe you can join us, Professor Maharabat. It will be a very honorful for us. So Professor Salman, maybe you can start the discussion.
Thank you very much.
Thank you, Ustad.
I'm really grateful, and thank you very much for introduction by Professor Khoja. In particular, deeply grateful to my good friend, Dr. Ed Kelly from WHO Geneva, and dear friend, Dr. Awad Mataria, for beautiful presentation. You put a lot of thinking now in our brain to think about how we shape our health systems. I think we have a lot of questions, and we will come specifically to the questions and raising point not only about today, but how the future will look like. Because honestly, if we look very carefully and listening carefully to both the presentation, there are gaps. To me, number one, that the health systems around the world were not prepared to such magnitude of pandemic. Why? This is a question which we need to ask maybe later, but it's an opportunity now to explore some of the points. Our priority now is to control the pandemic. Defeating the pandemic should be our priority. The second point to me is that actually people who need normal services, let us call it the essential services, whether I have chronic diseases or have some little bit of acute illnesses or part of my body need a maintenance or repair, you know, this is not happening or happening at a very reduced rate around the world, from dental, ophthalmic services, outpatient, inpatient, highly specialized services. And especially in some countries, there were a lot of concerns about patients with cancer. How can we avoid this in the future? How can we deal with epidemics or pandemics while we maintaining the normal services to ensure a healthier population and longevity? I mean, even a reduction in some of the preventive services was a bit of concern, and I'm very grateful for Ed presenting these beautiful slides showing in a survey among 82 countries around the world. My last point is how the health system will look like in a few years' time. I have absolutely no doubt it will look totally different. If I look at my NHS in the UK, today it's looked different. And we know that 60% of the services will continue to be delivered in totally different way than it was in January this year. So let us listen to my colleagues' question from around the Arab world and beyond. And Professor Khoja received a set of questions. Professor Khoja, shall we start with you?
Thank you very much, my respected brother, Professor Salman Rawaf, for your comment and allowing me to interfere. At the same time, really, I enjoy the two presentations. It is an excellent presentation, very comprehensive background, and really it highlights so many areas related to the health system and to today and post. As you said, there are so many gaps, but I receive, as I told you, four questions now. This is 5 questions, and it is a practical one. It is a practical one. 2 of them for Professor Edward Kelly, and the other 2 for Professor Awad Mataria. So may I start just reading it, and then we'll start by one by one. Dr. Edward, the first one: why health system in many developing countries and developing countries collapse or failed to facing the COVID-19 and has difficulties? Even all countries are more aware of the WHO health packages, essential health packages, for a long time ago. So why this is a situation happening? The second question: why, with all evidences we have and experiences learned from SARS, from avian flu, from other epidemics and pandemics, we came with these disruptions in healthcare delivery, as well problems in handling COVID-19? So I'll start with these 2 questions for you. The first one about the essential health packages. We have it, and at the same time we have collapsed and failed to face the problem in developed and developed countries. The other one is we did not learn from SARS and even flu, and we have disruption. So these 2 questions addressed to your good selves. Then we'll come to Dr. Awad Mataria.
Yeah, thank you so much, Professor Tawfik. They're really very good questions, and I think also very useful questions, particularly for the EMRO, for the Eastern Mediterranean region. Although I know we have people from around the world on, just because there's been such an emphasis on the essential, the package of essential services, and really instituting that. And maybe Awad will want to speak to that, but. Well, I have my own opinions on this. We have just gotten this data in, and we're starting to look at what are the things, the correlations between biggest interruptions and then other factors, like how well, for instance, how strong did countries rate on the UHC index, or were there other factors? But so I think we can come back and give a more evidence and data-informed answer to this in a week's time or more. But in general, I think we're seeing a few things. First, that this kind of health system collapse, COVID did not reveal anything that wasn't there before. It has really just shown the cracks that we have in our systems. If you, for instance, as a number of countries in the region who've had big spikes and difficulties managing some of the cases, have been countries that had good health systems packages, but they have not necessarily integrated some of the work on primary healthcare packages or universal healthcare packages with also the kind of disease surveillance and preparations for outbreaks. And I really think that's one of the keys. We have thought for many years about these 2 things as if they're separate, but when really it's the whole idea of strong preparedness and strong health security preparedness is really sort of version 0 for UHC. It's really the foundation for universal health coverage. Secondly, I think that you can see even in the first slide that I showed, a number of countries did talk about, we have an essential package, but they haven't put any money behind making sure it's staying running. But meanwhile, lots of funding coming in for infection prevention or purchasing personal protective equipment and that kind of work. So I think that that's 2 key factors that are there. In terms of why we have this collapse in terms of trying to address issues. So then the second question, Professor Khoja?
The second question is about, with all evidences we have and experience from SARS, even flu and other, we don't learn from this. Why?
Yeah, good point. Well, interestingly, maybe I will share the link with people in the chat or something, but it's I was looking back at a video that talked about why didn't WHO warn us about this earlier? It's been a criticism that's come from many, many countries. And if you look back at the start of this video, which has one of my colleagues and a great hero, Mike Ryan, who is the current head of the emergencies program, and he looks, you know, he looks as young as Awad Mataria does. He looks a very young man, but now he's, anyway, not to say he looks very old now, but he's much older. But 2005, he was literally predicting this exact scenario, and through SARS was the same thing. And I think honestly, we have not done a good enough job. There's been two things. One, the world made a decision, and this was a decision by member states, and WHO had to abide by it, but also WHO should have pushed more perhaps to invest in the sort of fire prevention, sort of the preparedness and prevention side, and to leave the response side aside. So to say, well, look, if we spend a lot of money on fire prevention, we won't have any more fires, but then we end up, of course, always having fires. So you need both. And we spent a lot of time on tools for analyzing preparedness, sort of the joint external evaluations, the sort of the NAPs, the National Action Plans for Health Security, and actually the independent oversight group for WHO, for the Health Emergencies Program, in a report they published and is publicly available, if I'm happy to share it, concluded that there's almost no correlation for countries that did very well on the joint external evaluations and had national action plans, and countries that did well in the COVID outbreak. So we have to analyze the tools that we're using and decide whether they're still good or we need to make adjustments. And we haven't done that. So those would be my 2 points, I think.
Well, thank you very much, Ed. I'm anxious about the time, and we will come to some of other questions, Professor Khoja. Let us speak from other line. We got email. And I do apologize. We did have an intruder earlier in your talk, Ed. We removed him.
Yeah, good.
That may be planted by someone against you, but I'm not sure. I sincerely apologize. We have a question from Qatar, which is quite reasonable, showing, I think you alluded to it, that pandemic exposed the weaknesses in health systems. And how can we bridge that gap and addressing the weaknesses? And I think if I may add to this question from Dr. Azzuddin, in saying not only weaknesses, I don't think health systems today around the world are fit for purpose, okay? And I think also, unfortunately, we don't have sufficient expertise in health system reforms around the world. So, I mean, if you combine these 3 points, I would like to listen to you and Awad about that and how should we address it.
Yeah, maybe Awad, maybe I defer to you go first and then I'll compliment.
I'll have the first part, Awad.
Sure. So thank you very much, Professor Rawaf, for this. And I think this links to the first question that you opened the discussion with, which was related why health systems were not prepared. And the remark that we have gone through different crises, different pandemics, and yet when COVID hit, we are faced with all these challenges. I think one of the aspects for me, is the definition of health systems. What do we mean by health systems? I mean, people and even us in WHO, we have been very much, many of us, I cannot generalize everyone, very much linked to this thinking of the building blocks, this thinking about service delivery and the sort of a provider-driven way of looking at health systems. So even the different components that I referred to, they are very much towards the service delivery part of the health system. They did not take the health system in its totality. I mean, nowadays, and Professor Maher Rabat is with us, she has been reminding us repeatedly of the importance of community. And now we see how important community is in preventing and in advocating for and in managing even the current pandemic. So how to bring community at the heart of the health system, how to situate the health system within its overall socio-economic and political and environmental spheres within which it exists. So for me, there's a question of conceptualization. I mean, we were trying to address these different pandemics, but doing the same thing that we were using before. And I think there is a very well-known say that if you repeat do things the same way and expect something different to happen, then you are highly mistaken. So what I think the learning for us from this pandemic is that we need to relook at health systems differently. And this is where step 0 that I referred to, and I think also Ed has also referred to it, is the very basic foundation of the health system. I mean, nowadays we see the importance of surveillance. Surveillance was not there in our thinking about health systems in the past. When we're thinking about emergency preparedness and response, and what you have been referring to, this was seen as a different parallel system that is not related to our thinking of health system. So as long as we see things in parallel, I think we will continue to face the same challenges. And our challenge now is to integrate all these approaches towards a resilient health system that leads us towards universal coverage and health security. At least this is how I believe the future should look like for health systems in the region and global. Thank you. Over to you, Ed or Professor Rawaf.
Yeah, I think that that it's true. This idea that's really the key. This that Awad has highlighted. I also think there will be a lot of I think there will be significant criticism. Anything this big will always have this kind of analysis afterwards, which is totally appropriate, about whether were we too focused. And I think this will come from folks who are sort of disease specialists or kind of emergency specialists. Was the world following the UN high-level meeting too focused on UHC and not enough focused on these kind of more nuts and bolts or hard issues? And actually, I think the issue is we weren't enough focused on it. And we were focused on, as someone who is involved on service delivery, I have for years felt that WHO has maybe spent a little bit too much time sort of thinking about the planning of health system strengthening rather than just the doing of health system strengthening. And we haven't, even in my area for service delivery, so I'm looking at myself, we've done a lot of work on conceptual framing of service delivery, on people-centered health services, integrated care, Declaration of Astana, all very important things. But what about like how you organize clinical services at the front line so that when a case comes in, you know what to do with it? Your clinicians, like who else is going to give advice on that if WHO and health systems are not doing that? So I think it's a wake-up call actually for health systems around the world to be more applied and focused. Yeah.
Dina, can we listen to your opinion, and then Maha, then Senna? Dr. Dina? Dina is not with us. Dr. Maha?
I'm with you. I'm here.
Oh yeah, carry on, Dina.
Yeah. No, it's very intriguing. Thank you very much, Ed, and thank you very much, Awad, for this thought-provoking talks. I would have to start from where Awad ended, is that community mobilization and integrating the community into the heart of working with the epidemic is an important thing. And from what I've been watching and observing is that in the previous outbreaks here in Oman, for example, we had a very strong community mobilization component that was integrated, and thus the community was advocates and were very much aware of the issues. And but things happen differently at different times, and because of the speed of things that happened here, the community was not prepared and they were in a shock. So how do we teach them? How do we reach out to the community? The modes of communication are different now from 10 years ago. People now communicate with Twitter. Now we have Zoom and we have all kinds of online platforms. But my question remains, is this where people get their information from? Do we know what information they have and where do they get it and who do they trust with their information? And in this epidemic, had the people been more aware, I think things would have turned out very, very differently. That's my own belief. The other thing is that I would comment on the, making use of what we know right now to identify the gaps in health services delivery and how we can change them. And especially looking at and addressing innovative approaches such as to improve the efficiency of clinical care and to improve the efficiency of response to the pandemic. For example, things like task shifting and utilization of technology, remote treatment, remote health education, all of these things. I haven't seen these much, to be honest. And then I have a question to you from my personal interest in access to healthcare. Do you see access to healthcare during a pandemic has the same definition as access to healthcare outside the epidemic, outside the time of the epidemic in normal times?
Good question. We'll come back to the question. Can I ask Her Excellency Dr. Maha Rabat?
Thank you very much, Dr. Salman. Thank you, Dr. Ed and Dr. Awad. The presentations were really enlightening, and they always keep revolving around the issue of health systems, service delivery, and the equity. I think it just raises the issue of the effect of this pandemic or the outbreak and how did it bring over the inequity part of the service delivery and even of the containment and the response, which really affected people indifferently, even in the way they are handling, understanding, or receiving the services that are due to them. Inequities are really very high, and this pandemic and outbreak has really highlighted this, whether we're talking system strengthening or whether we're talking the service delivery. And I really think that this is the time where we always say that we have challenges, that we have gaps. We really need to identify those challenges and gaps into a more practical way to lead the restructuring and the recovery for the coming period. I was just saying to you, Dr. Salman and Dr. Awad, we're still thinking of first wave, second wave, the health system strengthening, but actually we need to be thinking of reshaping the way the systems are functioning, reshaping them in a way that would really make them resilient to the needed and the over demand of the health services and health requirements which are expected following this recovery. We're not only seeing second waves from COVID-19, we're seeing the second waves and the pandemics from all of the neglected essential health services that definitely are affecting lower and middle income and less structured systems with inequality and with inequitable phase. So if we look to the future, how do we want to shape it? How do we want to restructure it? And saying resilient might be easy, but this requires like a full-fledged way of handling situations that are really ambiguous to us. We think that we know what is happening, but actually we're not really sure. We're only just feeling our steps. And as you said, we need things that are fit for our purpose, when sometimes our purpose is not really very clear to us, and we need to redefine it for this time, for the medium term, and for the longer term as well. And it's really very important to start it now. And this is the time for us to start and to begin the proper assessment of our response and of our systems, and in a way to collectively just pull ourselves together and push to the future in order to find a way forward for us to be able to sustain successes or to sustain responses that are needed. And there is no point of just having we're saying that we don't have, we stopped thinking vertically, but definitely we're talking communicable diseases or non-communicable diseases. We're not bringing them together into a one package of structuring systems and of service delivery. We're still, even with the financing part, even with the governance part, we think that there are two different mindsets that we tried to put them together with the sustainable development goals, but actually in reality, they are still separated and they are not really functioning in a way to support the resilience of the health system. So we need to rethink the way we see things and we interpret our needs and our demands for the future. Thank you very much.
Thank you very much, Dr. Maha. I'll come back to your last point about CD and NCD. You know, this is a very valid point. Professor Senna, do you have any comments? And I'll come to Professor Tawfik. Professor Senna.
Yeah, I just want to share the experience of Morocco in this COVID-19. While there was a lot of, many health systems were focusing on mitigating the impact of COVID on their patients and their human resources. In Morocco, the state and the government made a rapid response. Also, the health system made a rapid response to the pandemic. But still, there was a lot of things that were emerged, like this problem of human resources specifically, and the continuity of healthcare services. I want to talk specifically about human resources. As you may know, in Morocco, there is a huge disparity between regions, and the disparity between regions. And I think for in my country, it can be the first challenge that we should think about if we want to rethink the health system of the country.
Yeah. And Morocco is a very large country. What is now 45 million?
Yeah, 40, let's say 40, 43.
I added 5, no.
Yeah, maybe after the pandemic.
Okay, Professor Khoja, any comments?
Yeah, thank you so much, Professor Salman and my dear respected colleagues for their comments. I would like to continue with the comments of Professor Maha, and this is a question addressed again to Dr. Awad Mataria. She answers some of the two questions I'm going to ask, and the third one. The first one, did the EMRO, WHO, study the impact and the effect of lockdowns and curfew on the healthcare provision and universal health coverage in the region? If so, what are the main outcomes to learn for? The second question, Doctor, is also it has been addressed to some extent with Professor Maha, but again, it is addressed to you. How can we globally and in our region address the concept of health in all policies and whole government approach, whole community approach as a future strategy to face any epidemics in the future? And the third one, do you think that we learned a lesson from COVID-19 that we need to invest more in the primary health care and public health infrastructure and strategies in the region? And if so, what are the future plan of the WHO in this regard? So this is 3 questions.
Excellent question. I think, may I ask to hold the question now and give you more questions? So all the speaker and panelists, including you, Professor Khoja, we have from one of our distinguished colleagues in the region, well known to everyone in this group, and indeed among all the 2 speakers, Professor Lubna Al-Ansari raised the question, to what extent have international regulation and GHSI, sorry, which is I think, Global Health Security Index, correlate with the preparedness of health systems to combat COVID diseases or indeed any disasters that may happen. Again, our colleagues from Jordan, from the Middle East Public Health Network, Dr. Mohammed and Nusur, do we need to conceptualize universal health coverage post C-19? And I think this is quite a reasonable assumption. And I think, yes, we need, but we need to think how we conceptualize it. There is a question from Dr. Ahmed Yahya, and again, another concept of reconceptualize. In order to reconceptualize the healthcare system, and in the light of the social protection, shouldn't health insurance arrangement be revisited? I think this is a vital question. I mean, I think what is implied in this question, should government change their role? I think I support this question fully. How are we going to look from Naima Al-Qasir, our good friend, now she's in Bahrain, WR in Sudan. How are we going to look at strengthening locality system at community level? How can we translate and be at the field? How can we operationalize all these beautiful documents presented by the two speakers? So these are a set of questions. May I add to that the last point, Dr. Ed and Dr. Awad, from Dr. Maha, Professor Maha point, in terms of I think, manage over the years around the world because we pushed the whole agenda of NCD, and nothing wrong with that. But what we did within ministries of health, that we created silos of thinking. People shifting a huge amount of resources, unfortunately, from expertise in public health and communicable diseases, all shifted to non-communicable disease without thinking about the consequences. I, for once, being a director in the NHS at that time, I refused to do so. I looked at the clinical and public health services integrated way. I never introduced the term NCD. We look at conditions people experience, risk factors people exposed to. And I think unless we think about that consequences of building a vertical tower in our health system, we will not be able to move forward and conceptualize the things which colleagues projected. Too many questions to you both and the panels. Ed.
Yeah, very many good questions. And I think there's in there some answers too, but I think, I'm so pleased that to have the question from Lubna. It's a very great honor. I think that it's quite clear that we haven't looked specifically at, like, for instance, scores on the GHSI and then scores on the UHC index and how that then relates to for instance, these results on countries' self-reported impact on services. I think what would be more useful is to look at the same way we did a UHC index, to look at sort of an interruption index, like some key indicators across like the ones I showed, and to then look in a bit more depth. But I certainly think, on the one hand, it does call for a revitalization or reconceptualization of UHC and the role of government, and us, if you look at what I was showing in terms of the UN framework for socioeconomic recovery, the idea we have this window right now of health first as a concept for all of the other sectors, which at least anyway in my time at WHO, and even when I was with OECD and worked for USAID in West Africa before, and the US government, never has as the Ministry of Health, or health as even a concept, been in the forefront of the national government. It was always other things. And I think we have a window where if we as health people want to be seen not as the sector that kept people home and denied them their their salaries and all these things, but we're there as part of an overall recovery. I mean, it's quite clear that almost no government is going to be able to lock down again, even depending on how bad things get fully. There will have to be some way that we manage with public health measures. And I think then back to these points that the idea, the question that we had here, which I really thought was good, is access to healthcare during the pandemic different? Is UHC or is our health system different? It is, but I think only in that it's like the volume has been turned up on all of the problems. It's like it's shown the cracks. So for instance, health workers and health worker protection, we knew that, but we haven't done enough. And yet we now in the US, for instance, health workers are losing their jobs. It's been one of the industries the hardest hit in terms of jobs, ironically. So secondly, like the continuum of care, very important that it's not just about hospitals and access to ventilators. It's what happens before that. The reason we are getting so many people dying in our hospitals, they're coming too late. They can barely breathe. They're almost hypoxic when they come into the door. Also this question of the most vulnerable, dealing with the most vulnerable. Singapore had things well under control, and it re-exploded because migrant workers working, from other places did not have proper access because they're outside the formal system. So we knew that we must deal with the most vulnerable, but now it's like imperative. Otherwise, we will not solve it. And then the last 2 points is like also the demand side. Very much thanks for the points being made on that. I think it's very clear, even in my slides, that one of the biggest reasons that the system is collapsing is because people aren't coming. You talk to colleagues like my colleagues in Beijing, well now, before this recent outbreak happened in Beijing, everything had been calm for a long time, but still emergency rooms were empty. Nobody was coming. And I think this is an issue that we must tackle. And finally, the last bit is that this issue of the last mile is key. On New Year's Eve, this past year, for instance, Samoa, they have 15 ICU beds for the whole country, 15 beds with ventilators. All of them were full, but they were filled with young children with complications from measles, which, as many of you know, some of it's pulmonary. And that is a vaccine that we have had since 1946. So the idea that this vaccine comes and all of a sudden magically it's fixed, the health system, we must figure out the ways that we reach that last mile. So all of those are things we knew, but now we really better fix them.
Polio is a good example. This is a beautiful global view. Can we listen to Awad with the regional view on these questions?
Yes. So thank you very much, Professor Rawaf. I mean, great questions, great insights from all the colleagues. I'll reflect on some of those. I'll be happy to take the discussion further after the session. But let me start by the question of the lockdown and its impact. We have just started looking at the economic impact of COVID, and we produced a guidance note that is going to be publicized very soon about what has been the economic impact of COVID. So the impact of the lockdown and on other things. So its impact on health systems is part of it, but its impact on the livelihood of people is something that is really hitting hard. And how to look at what are the measures, what are the policies that countries can undertake in order to alleviate that negative impact on people and on the community. So we have identified some monetary and some fiscal strategies that countries can implement in order to alleviate that negative impact of COVID. I would like to reflect as well on the question that Professor Al-Ansari has raised. I mean, I came across a paper that was published, I think, in November or October last year. So just 2 months before the outbreak of the COVID pandemic. And in that paper, there was a classification of countries or health systems based on their resilience. And it is shocking to see, for instance, that US was classified first and UK was classified second. So these are the countries that we saw that they have been hit, maybe not the most, but amongst the most countries that have been affected by the pandemic. So for me, this is where the question of conceptualization has to be taken very seriously. So what do we mean by a resilient health system? And that's why I'm very grateful for the test that my colleagues, Dr. Mahrab Bot and Dr. Dina Al-Asfour and other colleagues, Dr. Wajida Anwar and others have taken that exercise to look at what we mean by a resilient health system, how we can build a resilient health system for the future that would be able to predict, to resist, to address any future eventuality of that nature. Also take it from an all hazard approach, not only pandemic in particular, but all sorts of hazards. So this is something that is very important, and that is where we need really to invest in the question of the essential public health functions that I was referring to. With regard to the question of UHC, of course, everyone knows that this is dear to my heart. I don't think personally that we need to reconceptualize what we mean by universal health coverage. As I mentioned, universal health coverage is what we want. We want everyone to have access to needed health services in good quality and with financial protection. Maybe what we need to reconceptualize is the way that we move towards universal health coverage. So universal health coverage, the same way as health security, our goals, our aspirations that we want to move towards, and this would not change. This is part of the values of individuals and of societies. But it is how to shape up the health system to allow us to move towards that goal. And maybe that links very much to the question that Dr. Tawfik has emphasized, the question of the health insurance, which is something that WHO has always said. Health insurance is not a system. It is just one instrument that is there to organize the way that you are managing the funds that is raised for health. And although countries have seen it as the way that to solve all problems, but we know that many countries, especially coming to the GCC countries, they were thinking that it is through implementing a health insurance program that all their health system problems would be solved, which is I mean, conceptually not valid, at least in my mind, in many of the minds of people who are thinking about health financing for universal health coverage. Let me take this last point, and maybe we can have more questions. That the point that was really fascinating, I like it very much, the idea of NCDs and investing in NCDs. You know, the risk that I am very much cautious about and really feel very bad and afraid from is that now the way that you presented it very nicely, Professor Rawaf, NCDs training most of the resources, that it might become health security, become the new agenda and the new baby on which everyone wants to focus. And that's why I would like really to see health security as part of health systems. The same way that we would like to see maternal and child health, NCDs, communicable diseases. It is without having that overall integrated approach, we will always miss the forest for the trees, and we'll always focus on something, and unfortunately it will have negative ramification, negative implication on other parts of the society and of the health system. So focus should not be on one part. We should start by identifying where are the gaps, what are the problems, and go backward in order to try to solve them in a systematic way, sort of. And thank you very much for all the questions. Really brilliant and exciting.
6 minutes. Any my colleagues on the panel want to add any point in what has been answered so far?
Just a brief point, Dr. Rawaf. I would like to raise the issue of the legal environment for providing healthcare. I think it's part of it is health insurance, but also there is a wider scope for, if you're talking about health system resilience, then you need to talk about flexibility in the legal environment that will facilitate health provision of care. One example of this, for example, public health laws that allow the government to provide health care for free. And also another aspect is the ethics of healthcare provision. We had recently a big debate here on donating plasma for COVID patients who are hospitalized by the patients who have recovered. And the debate was, are we supposed to make them donate, or are we, legally you cannot force them to donate, but this is for the benefit of the others. So the legal environment, I think we need to dig deeper into the legal environment and ethics of healthcare. And
the valid point. I know Ed is leaving in 5 minutes. Actually, we are closing in 5 minutes, Ed. So any comments about the legal duty of governments in terms of providing health and healthcare to its citizen? Ed?
Yeah, I think this is an very important piece that I think that Dina highlights there, that is often under thought of. If you look at, for instance, WHO, at the moment at headquarters, within all of our work on UHC, we have one focal person on the legal aspects of this and on the legislative aspects. And I think this is, it's often left to, if you look at many legislative processes around the world, the process of taking good concepts like what we've just talked about and putting them down into law is left for non-health systems people and non-sort of public health people. It's left to young sort of staffers for different legal people. So I think this is one area that we should consider, and it's something we've highlighted within the UHC work. But now there are particular new aspects of the legal questions that have come up vis-a-vis this interface between UHC and health security, all around all of these new apps that come around tracking our immunity status and other things like that, that are new legal questions that will push the boundaries a bit. So it's definitely a gap in capacity that I think we have.
I think it will shape our thinking for the future. I think your leadership on integrated healthcare is very important. And I think there will be more opportunities in the near future to integrate health services in totally different way. I just want to say that we are not critical of what's happening and what governments are doing. It's not the time to be critical. But I think because the pandemic took such a long period of time and all of us are locked somewhere in, give us more thought in reflecting and thinking how we shaping our health system or shaping our life, our work, etc. So I hope these are not received in any form or shape as a criticism. Indeed, it's constructive ideas and constructive thinking, and we should take it in that spirit. I think toward the end is my duty to, unless the panel got any quick burning question you want to raise, anything you want to add very quickly?
Yeah.
Okay. So at the end, let me thank the chairman, Professor Senna, for her leadership, and I'm really grateful and joy to have you with us. And Dr. Ed,
thank you, Professor Salman, for your invitation to chair this discussion.
You're welcome. And Ed Kelly, I know how busy he is, and I know he told me he will leave sharply after his presentation, but I'm grateful that he stayed with us to the last minute. This is an honor and privilege, Ed. Thank you very much. Likewise, Dr. Awad Mataria, I'm really grateful for being with us. You are always a great support to our group, and you are a member of our Arab Public Health Association. To my colleagues, Professor Maha Rabbat, thank you very much indeed for you being with us. I know you are extremely busy. Dr. Dina Al-Asfour, thank you very much indeed, and always your contribution and your work on health resilience, we admire. We have actually planned, Professor Khoja and I, various webinars for the future. Some of it, of course, we have a weekly one, and I think we started to use to it. In the new era of COVID, I think most probably will continue and change it into some educational system for our colleagues within the region. We have a session on primary care. We invited some colleagues from the region and outside the region. We have one on public health workforce and what does it mean, the new type of competencies needed in public health. And now we experience this pandemic, and we learned a lot of lessons. We have a session on self-care. All these will be shared with you soon. And thank you very much. And I exceeded the time by 30 seconds. I apologize. Thank you very much indeed for everyone. Thank you. Bye-bye.
Thank you. Bye-bye.
Bye-bye, sir. Bye-bye, everyone.
Thank you. Bye-bye.
Bye-bye.